You have a patient that comes in for a cardiac cath procedure. He's on metformin and lisinopril. Are you going to discontinue any of his medications? Yes, you're going to discontinue the metformin. Reason being that metformin given with large doses of intravenous iodine contrast can increase the risk for lactic acidosis. Okay? It gives contrast-induced renal failure in that situation. So most people will discontinue the metformin on the day of the exposure and then restart it 48 hours later after documenting stable renal function. What are other contraindications and or side effects of metformin use? Side effects include gastrointestinal upset, nausea, abdominal pain, diarrhea, decreased intestinal vitamin B12 absorption, and lactic acidosis. Contraindicated if you have abnormal renal function, which is defined as a GFR less than 30, or hepatic dysfunction. Other contraindications include active alcohol use, sepsis, and congestive heart failure, although patients with well-compensated heart failure and normal renal function tend to be able to tolerate metformin. A urethral diverticulum can occur in women who have had recurrent UTI infections or have also had multiple pregnancies, vaginal deliveries, or surgeries in the area. You will be able to palpate the mass anterior to the vaginal wall, and when you do a urinalysis, you're going to see some blood, some white blood cells, and you may also see some positive leukocyte esterase and nitrates. They will also present with urinary incontinence of dribbling after voiding. You do the formal diagnosis with an MRI of the pelvis. All right, you have a newborn that comes into the world, tachypneic, nasoflaring, costal retractions. You go ahead and you do a chest x-ray and you see that there's a flattened diaphragm, there's mild cardiomegaly, and there may be prominent vascular markings, maybe pleural effusion, some fluid in the interlobar fissures. What's going on here? So this is most likely transient tachypnea of the newborn. It's transient. It's going to go away within 72 hours. It usually happens due to, or the risk factors are cesarean birth, prematurity, or maternal diabetes mellitus. And this is basically retained fluid in the fetal lung. And so you're just going to give them oxygen and nutrition and let it go away on its own. No big deal. All right, let's say you have a lady that comes in, all the symptoms of stroke. You do a non-contrast CT, there's no hemorrhage. You go ahead, you give TPA, you blast a clot. The symptoms improve. Now at this point, what do you do? And you are post thrombolysis, okay? For the first 24 hours, you need to monitor the patient very closely, because during these 24 hours is where we have the highest risk for intracerebral hemorrhage. I mean, you just thinned out their blood very acutely, right? They can have systemic bleeding in other places like a GI hemorrhage, okay? And you also want to monitor their blood pressure and keep it under strict control. Now, the key numbers that you're looking at over here is 180 over 105. You want to keep the blood pressure below 180 over 105, but you don't want it to get too low, right? Because you also want to maintain perfusion to the part of the brain that was just ischemic, all right? So what are you going to do? You're going to give intravenous. Antihypertensives such as labetalol. Reason why? Fast onset, easily titratable, okay? You can control it much better. After the 24 hours are up, no complications have occurred, then you can start antiplatelet or anticoagulation. Right, gestational diabetes. The only time you screen for gestational diabetes in the first trimester is if the mother already has risk factors for pre-gestational diabetes that has been undiagnosed. So biggest example of that is obesity. if this is not the case, then you're going to screen for gestational diabetes during the second or third trimester, usually between weeks 24 and 28. The first thing you're going to do is a screening test, which is going to be the 50-gram 1 hour glucose tolerance test. You want to get a reading after 1 hour of swallowing 50 grams of glucose. You want to get a reading of less than 140. If it's not less than 140, then you're going to move on to the next test, which is the diagnostic test. This is going to be the 3-hour 100-gram glucose load. So you're going to give them 100 grams of glucose, and then you're going to measure their serum levels of glucose, I should say, at fasting before they take the 100 grams. Then you're going to measure it 1 hour after the 100 grams, 2 hours, and 3 hours. If you get abnormal values for equal to or greater than 2 of those measurements, then it's positive for gestational diabetes. Let's say you diagnose gestational diabetes. Now what you're going to do is you're going to recommend lifestyle modifications. The patient goes ahead and does that, and then they come back to the office a few weeks later and their blood glucose levels are still out of range. What are you going to do now? You're going to initiate insulin therapy. Now, insulin therapy is the first-line medication in gestational diabetes, has the best neonatal outcomes, minimal transplacental transfer, and is easily adjustable. Let's say the patient says, I don't want to use needles. I don't want to shoot insulin. What are you going to do now? Well, you do have oral anti-hyperglycemics that are available. The ones that you can use during pregnancy are metformin and glyburide. However, they're not too well studied, and we do know that they have a greater rate of transplacental transfer than insulin does. But they are acceptable alternatives. So she had gestational diabetes. She goes ahead and she gives birth. Everything is pretty much fine during delivery. And the question is, are you going to continue her insulin regimen that she had while she was pregnant? Absolutely not. The reason why she needed insulin in the first place was because the placenta was conferring insulin resistance. Okay, once that placenta is removed, this insulin resistance is going to drop dramatically. Okay, so what you're going to do is you're going to discontinue the anti-hyperglycemic medication. However, she still may have an undiagnosed pregestational diabetes. Okay, and so we're still going to screen for diabetes with a fasting blood glucose level 24 to 72 hours postpartum and a 2-hour glucose tolerance test at 6 to 12 weeks postpartum. In addition to that, we may also screen every 3 years because patients with prior gestational diabetes are at increased risk for type 2 diabetes. Epididymitis versus testicular torsion. In epididymitis, when you elevate the testicle, you get a relief of the pain. In testicular torsion, you do not. It just hurts and it will continue to hurt. Get it detorsed ASAP. Neonatal breast hypertrophy is a result of circulating maternal estrogen that crosses the placenta in the third trimester. So you can have both boys or girls have symptoms because of this. And basically, there may be a small amount of breast tissue and it can express milk when it is manipulated, right? So galactorrhea. In newborn girls, this can also express itself as labial swelling, leukorrhea, and uterine withdrawal bleeding. There's nothing to do about it. Just leave it alone. It's going to go away. When addressing a thyroid nodule, some of the main factors that are going to determine whether you do an FNA is going to be functionality of the thyroid tissue and the size. So a hypofunctioning or a cold nodule that has normal TSH levels is more likely to be malignant. And if the mass is greater than 1 centimeter in any dimension, is also greater likelihood of being malignant. So in both those situations, either or, you are going to do an FNA biopsy. Let's say you do the biopsy and you see that there are nests of polygonal cells with extracellular Extracellular polygonal cells, Congo red positive amyloid deposits, and this is consistent with medullary thyroid cancer. Big problem. Serum calcitonin is 300. You have a mutation in the RET proto-oncogene. What is the best next step that you're going to do right now? So usually when you have this cancer, you're going to go ahead and cut it out, thyroidectomy with a lymph node dissection. However, in this situation with this particular cancer, we know that this is part of the MEN2, multiple endocrine neoplasia type 2. So there are going to be so whenever you have somebody with medullary thyroid cancer, you're going to go ahead and do the genetic testing to see if they have that RET proto-oncogene. And if they do, then you're definitely going to have to rule out the MEN2 disorder. And one of the biggest things you have to worry about is pheochromocytoma. MEN2 is associated with pheochromocytoma in approximately 40% of cases. And if you're going to go ahead and do surgery to remove this thyroid gland, that can cause a life-threatening situation in the OR and lead to hemodynamic complications. So what you have to do is you need to screen for plasma-free metanephrines prior to surgery, okay? Prior to surgery. Concurrent otitis media with purulent conjunctivitis is typically caused by non-typable Haemophilus influenza. This is known as otitis conjunctivitis syndrome. Uncomplicated acute otitis media is treated with high dose amoxicillin. However, if you have a recurrent infection within a month, you're going to treat with Augmentin, amoxicillin, and clavulanic acid. If you have continued recurrence, if you have persistent infusion for greater than 3 months, or greater than or equal to 3 episodes of acute otitis media in 6 months, or greater than 4 in a year, this is where you start to consider myringotomy and placement of tympanostomy tubes. ITP versus TTP versus DIC. In ITP, you go ahead, the person comes in with petechia. You go ahead, you do some blood analyses. Everything is pretty much normal except the thrombocytopenia. So you have an isolated thrombocytopenia, right? They may throw in the question stem that you go ahead and give them a platelet transfusion and still the platelets are low or even lower than before, right? This is definitely due to ITP. So it's antibodies that are destroying the platelets. Okay, what are you going to do to treat this? If it's children and they have cutaneous symptoms only, you observe. If it's more than that, you can give glucocorticoids, IVIG, or anti-D if they start bleeding. In adults, same thing. Observation for cutaneous symptoms and platelets equal to or below 30,000. Equal to or above 30,000. If they get to less than 30,000, that's where you start to give glucocorticoids, IVIG, or anti-D. Let's talk about TTP and DIC very quickly just to kind of, get the difference. So TTP, thrombocytopenia, and microangiopathic hemolytic anemia together. Okay, that's what that is. So you're going to see schistocytes on peripheral smear, elevated lactate dehydrogenase. You may also have acute renal failure, fever, and neurologic abnormalities. DIC is much more complicated. There's more things going on. This is a consumptive coagulopathy. So you're going to have both bleeding and thrombosis, and it's usually associated with sepsis, trauma, malignancy, or obstetric complications. In terms of labs, the coags, you're going to see elevated D-dimer, PT, and PTT, which is showing you that there's a depletion of clotting factors. And you're also going to have a low fibrinogen due to the consumption. All right. You have a patient who comes in with acute decompensated heart failure and they have pulmonary edema. You go ahead and you give them intravenous diuretics and you put them on non-invasive positive pressure ventilation. There is no troponins. It's negative for troponins, and they're still uncomfortable. They look like they're not breathing too well. The oxygen saturation is 94. What do you do now? What you can do in this situation is you can give them intravenous nitroglycerin, a vasodilator, which is going to reduce intracardiac filling pressures and basically reduce the preload. Okay. This reduction in preload is going to alleviate the pulmonary edema. All right, you have an adolescent that comes in with isolated proteinuria. Nothing else is abnormal in their history. They haven't taken any weird drugs or anything like that. What is the most likely diagnosis? Orthostatic proteinuria, basically excreting a bunch of proteinuria when they're standing throughout the day and not excreting protein or very minimal protein during nighttime when they're laying down. Okay? You're going to diagnose this with a split 24-hour urine collection. And so you're going to collect urine through the day and then collect urine at night, and you see the difference between the two, and boom, there's your diagnosis. Once you diagnose it, there's no further workup or treatment needed. It is a benign condition that will go away. There's this very interesting little pathogen that can cause subacute bacterial endocarditis. And you may also just find it floating around in the blood, all right, as bacteremia. And it's called Streptococcus gallolyticus. Whenever you find this bug, either on a heart valve or in the blood, you need to immediately start looking for colon cancer, right? In about 25% of cases with people who have endocarditis or bacteremia with this bug also have a colonic neoplasia. If you have a patient from a foreign country that you're going to screen for tuberculosis and they receive the BCG vaccine, you want to go ahead and do an interferon gamma release assay instead of doing the tuberculin skin test. And I mean, these days, even if that's not the case, everybody does interferon gamma. The only time you're really going to do a chest radiograph is if the person has a prior history of latent TB. And you basically just want to do the chest x-ray to rule out any active disease process. All right, let's say you go ahead and you do the interferon gamma release assay and it comes out positive, but the person doesn't have any symptoms. You do a chest x-ray. That chest x-ray is clear. This person does not have an active tuberculosis infection, but they most likely have a latent tuberculosis infection, which at any moment can convert into active disease. So what you're going to do is you're going to treat. You're not going to do the 4 medication regimen. That's for active disease. For latent disease, you're going to do rifampin daily for 4 months. Done. Another option is doing isoniazid monotherapy for 6 to 9 months, but it's a longer time frame, more side effects, so it's not as well tolerated, right? So rifampin is the way to go. The one effective treatment for myelofibrosis, primary myelofibrosis, is allogenic hematopoietic cell transplantation. Patients aged less than 60 can be considered as candidates. If you're over 60, you're not. And at that point, palliative measures are the only thing that we can do. So doing transfusions essentially and giving erythropoietin. Factors associated with poor prognosis are a significant weight loss, hemoglobin of less than 10, leukopenia, and a platelet count of less than 150. Leukopenia would be defined as less than 4,000. If you have a patient that is approaching this point, they're greater than age 60, palliative care is the best option.